come up. Mpigie makofi tafadhali. Wesley Ogera will be talking about Ogera. It's Ogera. Yeah, we'll be talking about, this is Nigerian, eh?
No.
Yeah. Oga. Yeah, Wesley will be talking about health informatics from the point of view of MOH. Welcome.
Thank you. Good morning. And once again, congratulations on your appointment. So that will be basically my outline of what I'll be able to talk to you about. We deal with health information. I think information basically is what everybody needs to make a decision. So we have what is our definition. I'll take you through some of the health information systems that as a country we run through them. I'll also show you how data flows, because I believe all of you are aware healthcare in Kenya is only provided in two places. Either you're giving it at a health facility or at the community level. Then we'll lastly go through the health information systems, what are our weaknesses, where do we need to improve, and lastly, data management and the rest. I hope, as Waziris, when I'm done in the next 15 minutes, you will at least know what are the systems that we have in place, what are the reporting channels, who does the report, where is the data coming from, so that when you hear there's been a maternal death somewhere in your county, you can go and ask you where was it written and where was the data verified from. Then knowledge management, I think that will be just in passing. So there's this thing called HIS, health information. Someone might probably want to know what it is or what is it we do. Because even within the counties, I'm sure you've met someone called the county records officer. And you might ask what they do. Mainly, we interest ourselves, number one, collection. Then we collate. And then we manage our routine health data. As you'll be able to learn, there's some data that we collect every end of the month, and it tells us exactly how well are we going towards our either international requirements, or where, as we come in as a government, where do we want Kenya to be health-wise? How many mothers should we lose when they're giving birth? How do we intend to reduce such numbers, and so on and so forth. So the goal of why we collect that data, I think the lawyer stated you will mainly be at policy, to be able to answer some of our needs, patient and clients, our health providers, health managers, and lastly, there are policy makers and international players, because there are some requirements that we've made either in our international objectives saying we want to reduce maternal death by this and this, we want to reduce under 5 by this. So our main aim will be able to give that. So as we look at health data, we'll have it in two different formats. We have what is known as routine or continuous data. This is data collected at health facility or at community-based or vital registration, sentinel, or program. For health, our key ones will be those two, the first two, health facility and community-based. And as Waziris, my main aim, I'll ask and pray to you, look at the community. Those ones impact majorly. Those of you who've even monitored, and I'm sorry to say this about the politics of re-elections, community health workers have an impact on the ground. So community data is very, very, very vital. Those are the people who know your home, they know your babies, they know when he has a fever, they know when they're sick. People like me are just, in Nairobi, we are waiting for the data to be told 80 were sick. The community health workers know Mama Brian, mtoto wake alikuwa mgonjwa. Then we have the sentinel, vital registration will be mainly done by births and registration. We have sentinel reporting. A number of facilities in the counties are doing sentinel reporting, like for pharmacovigilance, anytime there's an issue with drugs and drug quality. Then we have the non-periodic, which will be household facility-based surveys, population census, rapid assessment, and research. Here, the main thing I want us to remember, household survey. I think next year, which will be next month, we will have the Kenya Demographic Health Survey released. Please get to know how your country is doing, especially towards at population level. How well are we doing? Those are some examples of those surveys. I think you know about it. I've told you about the number one that you're seeing there. Kenya Demographic Health Survey is going to be released. I believe I saw somewhere 17th, but I'm not sure. The small edition will be done. Please monitor it very well. It gives us a perspective of whether we're doing well, what is the trend. And please remember the challenge we had, our last demographic health survey was in 2014. So we are having a hiatus of about almost 9 years where we've not been able to measure. Now, These are the things that involve where I work, our health information systems. We'll have the KHIS aggregate. I'll briefly tell you what it does. We have the tracker, we have the master facility list, virtual academy, the service desk, and lastly I'll talk about medical records. And I think my boss who was previously here, Dr. Sitine, I'm sure has given you a glimpse of the DAMO and the Chanjo system. So I will not belabor in repeating what was already done. So we have the KHIS aggregate, and it's a tool for collection. Please remember that: collection, validation, analysis, and presentation of aggregate data, patient-based data. So this is what it means. If a mother comes to a dispensary for the first ANC, data will be collected, as I've said, in a register. At the end of the month, we want to know how many mothers came for first ANC in this facility. So we are not collecting individual data, but we are collecting an aggregate of that data. How many mothers delivered in these facilities? How many babies came for a particular immunization in this facility? We concern ourselves with collection of the aggregates, and it's validated so that, for example, if we had 50 pregnant mothers coming for first ANC, if we're asking how many were tested for HIV, if you give us 55, the system will not agree, because that system has some validation process to ensure that data collected is of good quality. Important data that comes to this system comes from the community and their facility level. At the end of the month, key data elements are aggregated from the registers into the summary tool. So the next thing you'll see people coming to your office is we have no registers. So if there is no register, that means whatever is happening at the facility is not being recorded. So registers are very key. Summary tools, we rarely go out of stock. I'm sure the next meeting you're having, someone will tell you an issue to do with our registers. We need to print registers. That is how data flows into this. So we'll have community level data collected in those tools, health facility in the different registers. After you collect it in the register, you do a summary in the summary tool, and then it's data entry at sub-county level. So as you'll be planning and thinking about the HR component, as person in informatics, my request is please remember the health records and information officers. They are mostly forgotten. We do all the work, and after we've done all the work, no one records it, and then it's not able to be seen up here. So please remember the health records and information officers. They play a critical role. There's a very famous line I've heard before. I don't know if you've heard it. There's a line that says, "In God we trust." Have you heard? Everybody else, what should you do? Bring data. So if these people are not there, you will be saying we've plowed this million into health, but the data will not be able to say anything about it. And then we have the tracker, and this is an important thing which I probably ask that we go and sensitize and ensure. This keeps special events that happen within the facility. For example, when you're admitted into the facility, when you're discharged, we collect all the variables so that we're able to know things that happen to you. For example, you might want to know, on average, how long are our patients staying in the ward? You know it has a repercussion of how much food the patient is eating. It has a repercussion of how much beddings, how much utilization, so that if someone is telling you, money you're giving me is not enough, please tell him, what is our average length of stay in our facility? So that I think averagely we can say, chakula ni ya 200 per day. So if on average our patient are spending 4 to 5 days in the ward, how much food do they require? So this is the kind of data, and the data is entered in that tracker, where we also enter major things about maternal deaths. We want to know the variabilities. Who are the mothers dying? Are they the under 14, under 15? Because that's a special cohort. Are they the older mothers? All that data will be available in our system known as the KHIS tracker. The next one, I hope I'm not very fast, is we have something called the Kenya Master Health Facility List. Please be aware that every facility offering services in your county has to be within this system for it to get something that is called an MFL code. For all the databases in Kenya that handle healthcare providing facilities, you must have a master facility code, KMFL code. I'm sure you've had a line like that. This role is given by the sub-county. Anytime you want to open a facility, the sub-county health management team will come and do an assessment. They will give us a report. They will enter it into the system. Important things that you should know about this MFL: it keeps pertinent data that do not change. For example, it will give you the name of the facility, direction. We have geocodes for all the facilities in Kenya. And you can also get the geocodes for all the facilities in your county and how they are distributed and by CAF level. It also gives you if they have been regulated. It also equally tells you about the infrastructure. What is the kind of water they're using? Are they using borehole? Are they using rainwater? Do they have access to a road? Because road is a key indicator for health. That is the KMFL, and you should be able to get access to it. We have the MOH Virtual Academy. Now, I think for the last 2 years, we've had a lot of changes. COVID came in, nobody knew what to do, we were keeping distance. So we decided to develop a virtual academy where it's an online learning platform. Learners can self-register and learn more about each of the new things that we have. At the moment, we have a lot of content. We have content on cancer, we have content on COVID-19, and we have content on all programs that have given us some information. So in case you want to know more information about learning, even the DHIS2 that I've talked about, the MFL, there are self-taught courses there where someone can be able to log in and get more studies. We have the MOH service desk, and this I should tell you is going to be very critical, especially when we start rolling out of DHP. I'm sure my boss, Dr. Sitine, has given you a brief of where we are heading digitally. So we have the MOH Virtual Academy, which asks as our support desk. In case you have forgotten your password, you need rights, you need some information, this desk is very, very important. So you can raise a ticket, and it goes to the staff I work with, and they're able to give guidance. This is where we're going, the last one. We have the electronic medical record. We must appreciate the fact that as a country, we do not have one, but there's one being developed, and I'm sure you've been told about the digital health platform. We lack standards for measuring EMR. Even as we develop them, the ministry, which is a national responsibility lying under my docket, we're developing standards for all EMRs that can be able to be used in Kenya. As much as a national EMR is not established, county governments have partnered with investors and in the sector to develop EMR that are used to manage patients' records at service delivery. I'm sure as you've come in, you've heard of Elephant, you've heard of Funsoft. I don't know which other one is in the country, because innovation always precedes law. Law will come later, just the same way with M-Pesa. We were already using M-Pesa before. We were told now you need to register. Otherwise, innovation tends to supersede legislation. So this is an example of what has been going on, especially in the medical field. So some programs, TB, immunization, for example, have also developed a program. I think you've heard about Chanjo. There's something called TIBU. There's something called Kenya EMR. And different ones, very, very different ones. So the challenge we've had with them is that they are in silos. They cannot be able to share information. One system might have me as Wesley Ooga, the other one has Wesley Ogera, and the other one has Ooga Ogera. And we are all referring to the same person. So the silos kind of system is something we are moving forward, and we're really hoping we can move away once the DHP has been able to transform. We have IQ Care. I think that just tells you something about them. Programs have been working on it. Just as I gloss over, these are some of the things as Waziris we move around. These are the major challenges we are seeing generally as a country concerning our weaknesses and our strengths. Our weaknesses is we have still manual based, especially at the dispensary. The worker still has to do the register, enter the name, the village, and the rest, which is really taking a lot of our time. We have inconsistency, inadequacy in printed registers. Please remember, anytime you're doing the budgets, ask our records officers, do we need registers? Because as I've told you, a clinician in a dispensary will see a mother, give drugs, take care of the patient, and the patient leaves. If that is not recorded, you and me will agree some resources have been used. That healthcare worker has seen a patient, some drugs have been given, and there's no record of such happenings. We have limited analysis. I think that will be able to go. My recommendation is improve data quality and visualization, fast-track establishment of integrated county government to invest in capacity building of county officers in charge of health records and informatics. Important slide there. At your level, I believe whatever you have on your desk is very, very much. So there are things we call dashboards. Kenya Health Information, the KHIS as a dashboard. And here I would like you to, when you go back, please go and talk to your health records officer. Please tell him to develop for you a user right to log into KHIS. And the most important one, let him give you a county dashboard. A county dashboard, I think all of us are familiar with a car dashboard. See, you know how it tells you whether the fuel is there, whether you need to go to service, whether you can give someone a lift or you can just tell them, go, my fuel will not get there. Please develop county-specific dashboards they can burn in the system that will be running monthly, telling you how many mothers have delivered, how many children have got immunized, how many mothers have died giving birth. So with the help of your county records officers, they can develop for you your specific county dashboard. At one go, you get to know where the county is going. And they can even give you trends. Are the mothers increasing or coming for services, or are they reducing? This is, I'll just part through it, data demand, because my colleague has really done a good work on this. This will be my ending line, and please take note of it. Number one, we have a Data Protection Act in place. For those of you with Elephant, I don't know if your people have registered with that commissioner. Anybody handling sensitive data? I don't know what is sensitive data, because I saw people giving their email there. I'm sure if I search your email, it will tell me who you are. If I search your number on Google, it will tell me who you are. So I don't know what is sensitive data, because I tend to give it to the watchman. Sometimes I wonder, this watchman has my email, my name, sometimes even wants my ID number. Please familiarize yourself with the Data Protection Act, because I've always wondered if all the watchmen will need to register with that particular commissioner. I am saying this in line aware that we have, a number of your counties have engaged a number of EMRs, like Elephant. Get to know whether they have registered as number one, data processors or data collectors. We have e-draft bill, which we are drafting. It's a ministerial job. Please get to read the draft bill, and you can request for it from my boss, Dr. CTNA, so that you get to know how it's going to affect your number of things. We have piloting of the DHP. I believe it's in Kisumu, and that's another county. I'm not very sure which county. Please get to know the lessons learned and be part of it. I'll also ask you that as you're planning and you're budgeting, remember the ICT infrastructure. We forget about registers. Registers generally cost my division about 150 million. That takes us about 2 years. You will realize for you, you will need about 12 to 15 million every year. If we go digital, we just need to ask them, can you click here and go forward? And next, especially for my systems, I'm requesting that you also plan for budget for their training on the updates. Technology, as you will know, keeps changing. If you remember those of us who were around when we had Nokia 3310, and now that we have an iPhone, technology has really changed. Let our health worker also get those updates and be able to train on them. So I think the questions will be on the plenary. Mine is to say thank you, and those are my contacts. Feel free, in case you have any issue to do with the registers. Please remember, our national does the template. I can be able to send for you to the templates before you print, so that you don't end up printing the wrong things. Always be in liaison with it. Otherwise, I hope I'm within time. Thank you very much. Be blessed.
Asante sana. Makofi kwake. Sijasikia. Makofi kwake. Thank you very much, Dr. Wesley Ogera. You still went before we agreed whether it is Oga or something else. So, fine. Now, may I call upon, again, this is a very heavy presentation. He did it very well, a very complex area, but very well presented. Now, I should call upon the next speaker. And this one is Steen Larsen, or Larsen, which is correct. Steen Larsen, please come. And he will be talking about healthcare financing. So the money is here. Are you seeing it? Karibu.
Thank you very much, Prof. Good morning, everyone. My name is Steen Larsen. I am the financial advisor to the Dunedin Primary Health Care Program. It's a pleasure for me and an honor to address this distinguished assembly today, and thank you very much. I should like to say this was a joint, was supposed to be a joint presentation, but but our previous colleague in the COG, Mrs. Regina Ombam, who is the primary author of the presentation, unfortunately she could not make it. So you will have to do with me, and kindly lower your expectations accordingly. This presentation is about healthcare financing. And let me just take you up to the start. There we are. County healthcare financing, seen in the background of sustainable health financing. Here we go. Oh, I've even got a screen down there. Great. These are the objectives of the session: to highlight significant challenges, to highlight the financing, and to highlight sustainable financing. The presentation has 7 steps. I realize that the time is short and I'll take you through them very fast, so kindly excuse if it all seems very rushed. But we'll go through the funds flow, county health budgetary allocations, significant challenges, general financing, the issue of pending bills, sustainable universal healthcare financing, and lessons learned. This is the organogram, and I won't go through this. I'll just leave it on the screen for a few seconds, because I'm sure that all of you are aware of its composition. Looking at county health budgetary allocations historically, there has been a very promising trend, and the counties have been setting aside more and more funds every year. And that, of course, is very positive, and it is a trend of which, of course, we hope will continue. The only issue here is, does the expenditure also reflect budgeting? So the counties have to ensure that not only are the budgets in place, but that the financing and the expenditure also follows that budget. The significant challenges, I'll just spend a little bit of time on this screen here. The significant challenges in the county health financing are inadequate investments in health, late and unpredictable disbursements from the central government. There's a high reliance on development partners, which causes unpredictability. There's an inability to ring-fence health funds. Not a complete inability. Health funds are to some degree ring-fenced, but not totally. There are inefficiencies in the health system that result in waste. And some statistics tend to point to the fact that about 30% of the resources in the health system are actually lost or are not used according to the plans. Cost of health care is a huge issue, and it is beyond a significant proportion of the population, with these out-of-pocket payments at 23%, which is, of course, a huge amount of the disposable income of a household. Finally, one of the biggest issues we have is resource starvation. The sector does not get the resources that it requires for many obvious reasons, and this, of course, results in the standards of service being lower than what would be optimal. And also, there's also a weak linkage between the county sectoral plans, the county integrated development plans, and the medium-term expenditure framework process. So these are some of the main challenges. I'll just take you very briefly through the historical parallels from the 60s and 70s, where it was input-based financing, to the 80s and 90s with the introduction of user fees. The first 10 years of this millennium, where the issue of financing was also changed. And then to date, we have the new constitution. We have the PFM Act from 2012, So there has been a consistent development, some of it going up and down, but certainly it is a sector which receives a lot of attention from central and local authorities. Very briefly, the legal framework on the operation and maintenance and running of health facilities. I won't take you through each and every issue here, but just to note, and it has also been discussed in previous presentations, the legal framework around the health sector and the health facilities and hospitals, etc., is just shown very briefly here. We have the mechanism was this the PFM Act with the creation of a fund account which allowed facilities to raise and retain and use the revenues, and then we had that the National Assembly had passed an act of Parliament which allowed for uniform application throughout the country. So there's also been some development here, a very, very positive development. And these are still developments are also challenges, and these are also some challenges that we are working with. Another big issue we have is on the issue of pending bills. The new administrations are now taking over the running of the counties, and you are also inheriting some huge unsettled bills. And as it's stated here, accumulation of pending bills is actually a violation of the law. And when pending bills are accumulated, this reduces and to some extent even eliminates the space for ongoing financing and ongoing funding of ongoing funding and also funding of new initiatives. So we have some problems, we have some challenges with the health departments failing to attain their own source revenue targets. There's a failure to ensure procurement plans align with the disbursement of funds. We have many issues of spending outside the approved annual work plan and budget. And to some degree, this is also based on poor planning, poor budgeting of capital, and poor planning of legacy projects that you are taking over from your predecessors. Shortly on mechanisms of accelerating sustainable financing, we would like to see an increase in public sector financing, and that would be through mandatory NHIF payments. It would be based on advocacy with the MCAs to increase county health budgetary allocations, that is with yourselves, to at least 30% of the health budget. Then there would be on-source revenue, how to optimize on-source revenue, and then strategic purchasing to reduce procurement costs. On the side of private capital for achievement of universal health care, there's collaboration with public-private organizations. I'll speak a little bit more about this just afterwards. So we have public-private organizations which are both for-profit and not-for-profit. And with these collaborations, we can shift part of the expenditure from funding just to financing. To say a little bit more about private-public collaborations and public-private partnerships, there's a difference between the two. Public-private partnership is an arrangement between a contracting authority and a private actor. And the private party receives a benefit for this, or rather both of the parties receive a benefit. But for the private partner, they would have to receive a financial benefit also for it to make sense for them. For the PPPs, the benefit is usually to the private sector partner is usually compensation from a public fund or user charges. But PPPs involve risk transfer from the public to the private sector, and that's what private partnerships. The public-private collaboration is another level of cooperation. And here, all arrangements and partnerships are between a contracting authority and a private actor, including those that meet the public-private partnership thresholds, but also those that do not. And this includes that the partnerships are of a lower value, the partnerships are of a more manageable, the public financial or a non-financial benefit from the arrangement. The PPC, just to show what it can contain, I'll get onto that a little bit later. Let me just take you back here. I'll just explain a little bit later on what types of collaboration can take place under the PPC. But let me just first go to this, the PPC strategy and resource guide. There is a pamphlet out or a booklet out called the Kenya Health Public-Private Collaboration Strategy from 2020, developed by the Ministry of Health. And it's very difficult to see the link there, but we can highlight that link later on, and we will distribute that link later on. These are some of the types of collaboration that can take place under the PPC. Hospital laundry services, for example, could be contracted out to a private contractor. Service level agreements could be made for maternity services, for example. There could be joint supportive supervision. There could be sharing of staff. There could also be staff secondments to faith-based organizations, to the facilities run by faith-based organizations. And the public sector could also support private sector actors with commodities, but also the other way around. Then there are specimen referrals from public primary facilities to private laboratories. Let the private laboratories make some of these tests. There could be joint planning and execution of inspections and supportive supervision in private and public facilities. And then, needless to say, there could be information sharing and joint data reviews. There are quite a number of other areas. This is just to give a short example, a brief example of what can be done. But there could be a lot of other areas, and it would not be like a standard framework, because each of the counties, you have your own specific challenges. But this is just to give you an idea of what public-private collaboration can do. I will stop the presentation there. I told you it would be very brief and I would rush through it because our time is very short. But at the plenary, you're very welcome to put your questions. And a colleague of mine, health systems strengthening specialist, Robert Rabando, will also be there to answer any questions. So thank you very much for that.
Very good. Well done. Makofi kwake tafadhali. We got more than what we expected. Asante sana. Very good. That was a presentation from Steen Larsen. And now we will get another presentation in the same sector from Vincent Odini. It's not on your programs because part of what I said was there will be changes, and this is one of the first changes. So Vincent Odini will be talking about THS project and Danida PHC program. Please, Vincent, come in. Makofi kwake tafadhali.
Thank you very much for that introduction. I'll start by saying my name. My name is Vincent Odini. I work with the THS project, and also the Danida Primary Healthcare Support Program. So just congratulate Waziris for your appointments, your recent appointments. And for this presentation, we'll just majorly emphasize on the key emerging issues that we felt that will be very important to bring to the attention of Waziris as we implement both the THS and Danida programs. So I'll try to keep within the time that I've been given, though we always say that for the THS and Danida programs, there are two very heavy programs with a lot of things going on at the county level, and also, of course, at the coordination level, both at COG and MOH. So just allow me to start the presentation. This is just a brief outline of what we'll be looking at under the THS. I'll finish with the THS, after which I'll proceed to the Danida section. So we look at a brief introduction for the sake of Waziris who are new and joining us. We'll also look at the project minimum conditions, which of course need to be followed by the counties to be eligible for funding. We look at just a brief status on the implementation progress, something on the FY 21-22 funds. I know that will bring some issues in the room, and also some asks to the counties that will need you to take home as you go back to your respective counties. So just in brief, the PDO for the THS project is to improve utilization and quality of primary healthcare services with the focus on RAMCA. So the key focus is reproductive, maternal, newborn child, and adolescent health services. The second part of the PDO also reads to provide immediate and effective response to an eligible crisis and emergencies. This was triggered following the onset of the COVID-19 pandemic back in 2020, where we had some funds being channeled towards supporting response activities to the COVID-19 pandemic. So just an overview of the THS project in brief. Component 1 targets improving primary healthcare results. It uses a performance-based approach and employs, like I said, minimum conditions to allocate resources to the counties. We also have component 2, which is implemented at the national level. And the three main areas are improving quality healthcare. You've heard of the joint health inspections in your respective counties. The strengthening M&D and CRVS and supporting health financing reforms towards universal health coverage. We have component 3, deals with enhancing cross-county and intergovernmental collaboration. Back in 2018, 2019, thereabout, there was a call for proposals that was made, and there were some counties that were successful and have been implementing that intervention to date. Then component 3 also covers project management. Component 4, of course, is the contingency component, contingency emergency response component that I mentioned earlier was triggered after the onset of the COVID-19 pandemic. So just a little bit more on component 1. So under component 1, counties are given funds to scale up, of course, evidence-based and county-appropriate interventions. These interventions are in line with the RAMCA investment framework 2016. So we were initially set to end in September last year, but we were given a two-year no-cost extension. Of course, the justification we gave is that the delay due to the COVID-19 pandemic, and also the first year of implementation, we were not able to disburse funds to the counties, that is financial year 16-17, and therefore the first time the counties received funds was in 17-18. So we requested for an extension to cater for the first year where funds were not disbursed, and also to cater for the delays due to the COVID-19 pandemic. So we were given a 2-year no-cost extension till September next year. We are therefore working towards having the counties complete implementation by 30th of June 2023. So just a highlight of the project minimum conditions. I know we've already disbursed all the funds under THS. 21-22 was the final year of disbursement to the counties. However, it's important for the sake of new Waziris just to look at the minimum conditions that the counties were required to meet for them to be eligible for funding under the THS project. First of all was, of course, having a special purpose account with chief officers, health and finance as signatories. This is important because with the transition that we've had in the counties, we'll need to ensure that we follow up and have this done to enable utilization of the funds moving forward. We needed to have a project implementation unit made up of the focal person, auditor, accountant, and procurement officer. We also require the counties to develop an annual work plan and receive approval from the World Bank before they can implement the project. Budgetary allocation to health, where we require the counties to have at least 20% being allocated to health, and rather 30% being allocated to health. And for those that were below 30%, they needed to demonstrate an incremental trend year after year. So, for example, if you are at 17-18, you are at 22%, you needed to demonstrate that in the subsequent year, you had increased the allocation for you to be eligible to receive further funding. Then, of course, submission of quarterly and financial and technical reports, and also transfer of funds from CRF to SPA within 15 working days. So once the funds hit the CRF account, you are required under the project to have these funds moved to SPA within 15 working days, failure to which there were penalties that were being applied in the next financial year. So as the project geared towards closure, we had some conditions put in place for financial year 21-22, where we needed the counties to have attained 80% expenditure documentation rate for financial year 2021 as at 31st March 2022, which was this year. That was when we were compiling the disbursement list to the counties. And we had 30 counties that met this condition, 17 did not, and therefore were not eligible to get funding for financial year 2021-22. We'll be looking at the counties later on as we continue with the presentation. Then publishing of completed contracts. We have the World Bank STEP system, systematic tracking of exchanges in procurement, where upon completion of each procurement contract, the county is required to publish on that STEP system. The counties are not doing very well with regard to this, and we've been following up with the procurement officers, the technical teams at the county level to ensure that all completed contracts are published. So as we also go back to our counties, that's one of the things that we need to look into even as we work towards successful completion of the THS project. Then there were some audit issues which all the counties were able to submit action plans, and were then assessed by the PMT, and all the counties qualified with regard to that condition on the audit issues. So just something on the progress. So far, under the THS project, we've disbursed 11.3 billion to the counties. That is from financial year 17-18 to financial year 21-22. We are currently at 84.4% absorption rate. For the last financial year 21-22, we had 1.45 billion being disbursed to 30 eligible counties. So 17 counties, of course, like I mentioned earlier, did not attain 80% expenditure documentation rate, and therefore missed out on the funds. Just to move on quickly and flash the counties. So we had 30 counties that got the funds, as you can see on the screen. The 17 that did not get the funds include, as you can see, Kwale, Lamu, Mombasa, Garissa, Taveta, Turkana, Uasin Gishu, Nairobi, Baringo, Bomet, Marsabit, Meru, Samburu, Bungoma, Busia, Homa Bay, and Trans Nzoia. So we'll be sharing this presentation after this meeting, so you'll be able to look in detail and refer to the same and follow up in case you will need further clarification. So what are we asking the counties or the Honorable Waziris to help us or to follow up as you go back to your respective counties? Number one, you know there were funds that were carried over to the current financial year from previous financial years of implementation. And you find that there are some counties that are not included those funds in their approved county budgets. Sawa sawa. So what we are calling for is to ensure that these funds are appropriated in the supplementary budgets. I know most of the counties are in the supplementary supplementary one budget process. So kindly let's have these funds included there. And it's our sincere hope that we can have the supplementary budgets the approval process expedited in the counties so that within the remaining period, we are able to have all the funds absorbed before we close the project. Then we need counties to fast-track implementation and documentation of expenditures. Like I said, the end date for implementation, we've set it at 31st March. End date for payments, 30th of June. We wouldn't want any pending bills to be accrued from implementation of THS activities because, as I've said, we are closing next year. And if we'll have any pending bills, I'm sorry to say that the county will have to return the money or have the funds reverted back to the World Bank. So we are calling for a close working relationship between the county departments of health and finance. From our experience, we've seen things move, we've seen things work in counties where the health and finance departments are working closely together. But in the counties that, for one reason or the other, there's not enough synergy in moving things, you find that implementation is delayed and documentation of expenditures is thus a problem for those counties. So we had a final reprogramming window that we opened till early December. We've been able to extend a bit because of a lot of competing activities under the project. However, for this final reprogramming, we were calling upon counties not to include any procurement activities, because from experience, procurement activities have really caused great delays at the county level in terms of having activities completed and things documented in good time. So we were able to share a guideline on this. I think you received it officially through the COG communication channel. Then we are also asking to the Waziris to ensure that the new chief officers have the rights or the being made signatories to this special purpose account for the THS project, and also to have the tokens transferred to them to enable that seamless implementation of the project as we near completion. More asks to the counties. So with the ongoing transition, we've noted that a lot of counties are moving these project implementation unit members that I mentioned earlier, the accountant, project accountant, the project procurement officer, and the project focal person. So we are kindly requesting the counties to ensure that you retain these PIU members even as we approach closure, because we really need the institutional memory and we'll really need their input and technical advice as we compile the final report and also as we close shop and ensure that everything is done for the project. Then we also have audits that have been done. We are asking the counties to follow up on the issues and ensure they're addressed. Branding of assets acquired through the project has been a challenge for a lot of the counties, where you find a lot of items and equipment procured through the project are not appropriately branded. We are calling upon the counties to ensure that is done. And finally, we'll be having a final completion report being consolidated. We've been working on this template with the technical officers during the ongoing performance review meetings, and will therefore be requiring, of course, the Waziris to be instrumental and to help us in having this process done as we close the project. So thank you very much. That was for the THS project. I hope we've been able to get insights on what the project is all about and what we need to do. So we'll then move on to the Danida Primary Healthcare Support Program. I'll just brush through the slides because I'm seeing that I'm almost running out of time. Then we'll share the same and we'll allow us to ask questions later and to follow up even as we go back to our counties. So for Danida, that's the outline. Just focus the same way we did for the THS project, very fast. So for the Danida PHC program, you find that, I can't continue, okay. Yeah, for the Danida PHC program, the aim, of course, is to improve primary health care and to improve RAMCA services, same as I said for the THS project. So the total budget was about 2.4 billion with additional funding of 1.2 billion. So what is important to note for this program is that it's likely to be the last phase of support to the Kenyan health sector, and therefore sustainability is key. We therefore put in place a counterpart funding modality where year in, year out, contributions from Danida will go down as the contribution from the counties as counterpart funding is required to go up. So we also had an MOU that was signed by all county governments that outlined all the roles of the key implementers. That, of course, includes COG, MOH, Royal Danish Embassy, and the respective counties. So minimum conditions under the Danida PHC program, allocation of at least 22% to health. What is important to remember is that the grant supports operations and maintenance costs as defined in the GOK chart of accounts. And kindly, Waziris, let's not have the funds being channeled towards payment of salaries because it's outside the scope and it's not allowed by the PHC program. So like I've mentioned, the counterpart funding modality, and we are required to appropriate the funds in the county annual work plans and budgets for every year. We'll have a more detailed outline of that as we go on with the presentation. So these funds will be sent to gazetted level 2 and 3 health facilities. I know gazettement of health facilities has been an elephant in the room, I think in some counties. As we have the performance review meetings with county teams, many of the counties have raised concern that there are some level 2 and 3 health facilities that are yet to be gazetted and therefore are not then eligible to receive these very important funds. Yet if something can be done, they can then be put on the list. Then allocation criteria and distribution schedules. I think most of the counties have been doing well with regard to submitting this. We also require funds, counties to transfer funds from CRF to SPA within 15 working days and subsequently to the health facilities within 10 working days. And finally, qualified audit reports from the Office of the Auditor General is also another thing that we require before a county is deemed eligible to receive funding under this Danida PHC program. So just a bit of history. I'm winding up. Just a bit of history. In September 2021, we had additional funding to the grant. I had said initially that the grant was worth around 2.4 billion Kenya shillings, but we had 1.2 billion added to the grant. Through different meetings between COG, MOH, and the counties, we were able to decide that this additional funding of 1.2 billion will be used in this way: 800 million towards having a more gradual phase out of the grant, with 400 million going towards strengthening level 1. So some amounts also allocated towards developing M&D frameworks and also coordination mechanisms after the World Bank THS project comes to an end next year, bearing in mind that the PMT that coordinates THS, we are the same team that oversees or rather coordinates the Danida program in the counties. So just at a snapshot, you can be able to see how the counterpart funding modality will work over the years. From the current financial year 21-22, sorry, from previous financial year 21-22, where we had 75% from Danida and 25% from the counties, and down till financial year 26-27, where we'll have the counties expected to take up the overall funding for the program. Support to level 1, a bit of funds were put towards this. That's 400 million spread out across 3 financial years. So you find that the amount is not so much, and therefore we encouraged counties to be prudent in selection of the community units that they will then pilot this intervention during this current financial year. And from the lessons that we learned from the first pilot year, this current financial year 2022-23, those lessons will then inform you as you move forward and implement the grant or support the community in subsequent years. So the last funds that were disbursed for Danida, that happened in June of the previous financial year. We had the delays, of course, in the county government's additional allocations bill, which made us really delay in having these funds disbursed. We'll be looking at that as we wind up with the presentation. So I've said that counterpart funding, I say I have 1 minute, but I'll be able to finish. Counterpart funding is a very important element of this Danida PHC program. I'm sure I've said that over and over. So we'll then be looking at the counties. The purpose of this is not, of course, to victimize any county, but just to bring to the attention of Waziris that as you go back, you need to really look into that to ensure that your county remains eligible for funding in this current financial year. So we are looking at financial year 21-22, the last financial year, where we had funds go out in June. So as we speak of the current status, there are still 6 counties that have these funds in SPA. They haven't been moved to health facilities, so kindly let's follow up on that. That's Embu, Baringo, Samburu, Marsabit, Kakamega, and Migori. And then there are those counties that still have the funds in CRF, that is Wajir and Turkana. In case there's been an update on this information, kindly share the bank statements. Ensure the bank statements are shared with the respective cluster coordinator so that we are then able to take stock and update our reports accordingly. Because you find that there are some counties that have moved the funds, but have not shared the bank statements for verification with the respective cluster coordinators. We'll move on to the 25% counterpart funding for the previous financial year. Tena kuna a few counties that have not transferred the funds to health facilities. Muranga has the funds in SPA. 10 counties, as you can see, still need to have these funds disbursed to the health facilities. Sawa sawa. You can see the counties there. There were audits that were conducted by Ernst & Young, covering financial year 21-22. And there were still some counties that had pending information they were supposed to share with the auditors. The pending information varies. You find that there are those that are not submitted or shared the county budgets. There are those that are not shared some schedules, payment schedules and the like. So those are the counties that need to look into that. The Ernst & Young team gave us an update as at 7th of December 2022. So in the same way, if the county has moved or has addressed this, that needs to be brought to the attention of the auditors kindly so that we are able to update that. Budgeting for funds for the current financial year 22-23. We still have some counties that have pending documentation for the auditors to be able to verify. Those have been listed there. For Nairobi and Lamu, the audits are still pending. We've put there that the audits are still pending. For Mandera, the review was ongoing as at 7th of December when we were compiling this report for this meeting. Then those that have not budgeted for 60% Danida contribution for this current financial year, Isiolo, Kiambu, Migori, Turkana, and Trans Nzoia and Muranga, yes, from the auditor's findings, you budgeted, but you budgeted less, that is 50%. So you need to see how that can be increased in the supplementary budgets. Budgeting for counterpart funding for this current financial year, the counterpart funding now for this year, you can see that there's pending documentation to be given to the auditors from Baringo and Kwale to have that proven. Those that had not budgeted at all, the auditors were able to review their budgets but did not find any evidence of budgeting. You can see the count is there. Kindly let's follow up on that to ensure that we are eligible for further funding. Elgeyo Marakwet, Garissa, Isiolo, Kiambu, Kirinyaga, Migori, Mombasa, Nyamira, Nyeri, Turkana, and Machakos, you budgeted 23%. You need to have that ramped up to 40%. This you'll be able to look at as I share the slides. There are some unspent balances from the previous UHC grant. Kindly for those counties, we put the amount and also the status as at 7th of December. So you'll be able to look at this as we move on. So some asks to the counties, kindly urgently transfer 21-22 funds for those that have been seen to have pending 75% from Danida and 25% from the counterpart funding. Kindly let's follow up on that. If you've not included the Danida PHC funds in your current financial year's budget, please let's appropriate the same in our supplementary budgets. Same applies for the current financial year 22-23. Let's please have that done. Audit issues, same as THS. Audit issues, very important because they determine eligibility for further funding. Then we sent out a letter on appointment of Danida PHC county focal persons. We need these focal persons for two main reasons. Number one is that, remember I said we, the PMT for THS, are the ones that coordinate the Danida program also. And we'll be exiting the stage next year because THS project is coming to an end. So kindly, tafadhali, let's, in consultation with the county teams, let's have Danida focal persons appointed. Let's have that done in official writing and shared with the respective cluster coordinator so that we have it on record and we'll then forward the same to the Danish embassy. And also there is that support to level 1 that is in the current program. As you appoint that focal person, you can have that at the back of your mind that there's that expanded support to level 1. And it will be important that that person is able to follow up on, of course, level 2 and level 3 facilities and also the support to level 1. Then finally, this is, of course, to COG, MOH, and all development partners. We need concerted effort to continue pushing for early approval and enactment of the county government's additional allocations bill. Remember, for the last financial year, that was enacted in May, just 1 month to the end of the financial year. And it caused a lot of issues. First of all, you find that we were only able to disburse tranche 1. Tranche 2 did not go out. We hope it will go out this financial year or the next for the Danida program. And you also find that it also, of course, led to a lot of issues because the counties then are required to run around and try to move those funds before the financial year comes to an end in 3 days or so. Because we disbursed funds on 27th of June, which was just 3 days to the end of the financial year. And once the financial year turns, you find that it brings a lot of complications in having these transfers being made from CRF to SPA and from SPA to health facilities. So that was the presentation for THS and Danida. Thank you very much. And
Asante sana. I was tolerant because this is money that is already there. And you need to get this money. So you are not going anywhere. Please sit here. The rest of the presenters, please come forward so that we quickly do some arithmetics here. And if you feel like juice or a cup of coffee, just pick and come back because we want to finish early so that we can have the elections early this afternoon. Please, presenters. Christine, I can see you. Wesley, I've seen you. Eugene, where are you? Please come. And then Steen Lazen. Where is Steen Lazen? Yeah, he's coming. And of course, Vincent is here. So what I expect from the audience is questions. And please direct it to a particular person so that it is easy for us to manage the responses. Well, where do I begin? They've always started somewhere. Wacha nianze huku. Yeah, ngoja sababu huku ni kwangu.
One short question. Okay. My question goes to Wesley, and it's about the EMRs that you talk about. I think you're doing some good job, but having come from that field myself, I feel as a government, we are slower, and that is why we have partners coming in to fill space with a lot of apps. And yet we have our DHI system that has the capacity to do tracker data, meaning we can follow even individual patient records. And now we are struggling with printing tools, which I consider it unnecessary. Why can't we quickly inbuild, or what is the plan? And inbuild some of these registers. MOH ANC register should get it in the DHI system. I use it as a tracker, and we are able to get data disaggregated rather than waiting for someone else to think about that. So I just want to challenge you and ask you, what do you have for us? And as you talk of DHP, does it have this capability? Are we able to be getting our registers, all those primary tools in a system like DHIS, which is already popular with the people? It's already there. You don't need to set up anything else. Maybe just expanding the capacity of that.
So that was for Wesley? Okay, quickly.
Thank you, Dr. Home from Meru.
Be clear in your in the mic.
Okay. Dr. Home from Meru, this to Eugene concerning HR. Just two observations. One, in your presentations, we have seen that the medical officers, in terms of numbers, and also the medical specialists, are almost going towards the same in terms of numbers. That tells you that's an anomaly, which I think even as counties we need to start discussing with. When you have a specialist, which the numbers are almost equivalent with the medical officers, that's an issue we can discuss around, because ideally it should be like for one specialist with around 3 medical officers. Secondly is the issue of what we have been seeing in our counties. I don't know whether the rest have observed that. The aspect of employment when it comes to the counties, much of the staff we are getting are local. Allow me to use the word local. So the challenge comes with aspects of disciplinary. I don't know how we can be tackling this going forth, because when we have localized so much of our staff, in one way or another, they know the people in the county. You're trying to discipline them. There's a lot of canvassing going around. I don't know whether it can be a consideration under the COG, where they can come up with a mechanism where I would use the word delocalization of our people, so that we don't have too much inbreeding within the local setups hearing. Thank you.
Thank you very much. Give it to Dr. Eda. That's Mandera.
Yeah, thank you very much. My first question is to Lawi. In as far as the management cadres, I know the directors and you know the CHMD, these are not largely striking cadres, but the medical superintendents and other lower levels of county managers, what do you advise as we appoint them to the position? Do we also make them sign, you know, that they will not take part in any strike legally? My second question goes to, again, Oga. As far as technology is concerned, what you are developing and what we have experienced previously, sometimes you tend to get some sort of technical hiccups, and you have to now go back to the provider to be able to do some troubleshooting, to be able to clear whatever is causing the problem. How will maintenance and troubleshooting of the systems that you are developing be, so that then we are confident that at any time we get problems, then we are able to reach you, so that then these issues are resolved? Because that's the biggest trouble for me with this technology. Thank you very much. Those are my two questions.
Very good. Next row, please, quickly.
Yeah, thank you. This is Peter Marogo, CSC Kilifi. There's two questions to Eugene. He talked about the issue of the training, the challenges that we are facing, and the request that we've made to MOH to pick up that cost. And this is 10 years, and down the line of devolution. Is this issue ever going to be resolved? I know you throw it to the HRH committee, but I mean, here it is. We are committing resources. This issue is just, on discussion and advocacy, and it's not moving. Do you see, this issue ever being resolved if the ministry is not responsive on this issue? The next one is on the UHC staff. Which you said that by end of May, these guys are out of service. You have requested the ministry to chip in to be able to support the transition. They've been quiet. So, 30th of May, do we let them go? What happens? Then the last question is for the Danida colleague. Just a very simple question. With the funds that are dedicated to level 1, when you send the funds, is it clearly sort of earmarked in terms of this is the amount that goes to level 1 for purposes of follow-up from our side? Thanks.
Thank you very much. Who is next? Quickly. Name and where you come from so that they can respond adequately.
Thank you very much. My name is Franz Dwiga, CC Health, Embu County. This one goes to Wesley, my friend. One thing is that you have said that we really need to invest in ICT. And one of the key components we are worried about is issues around the systems that we have been developing in Aviaus, that they don't see the light of the day in terms of looking at how we can even be able to come up with a standard that all of us can then be able to comply to. So my question is, do you have any evaluation reports that tells us the status of the country in terms of public sector and even private sector? Where are we in terms of compliance to the systems that you people you are advocating for us to adapt and invest in our country, in our counties? Thank you very much.
Asante sana. Let's go to the next row. Who was going to ask a question here? Hapa hakuna. No question here? Yeah, okay. Tumalize huko. Hamna swali.
Thank you. My name is Peter from ESAID, a HRH specialist. I think I want to approach the issue of strike in a different way. It has been proven that bringing closer the workers' representative make it much easier to engage and also on a regular basis discuss so that they can understand where the county is and the counties also can understand where they're coming from. And this has been very effective in some of the counties I've worked with under what we call county work councils. So I think the best approach is to have the two parties engaging on a regular basis so that they can get to understand where they're coming from. Most of these strikes come because of lack of understanding between the two levels. I think that's the best approach in my understanding. Thank you so much for that.
So my name is Maxwell Marks. I'm with PEPFAR. I'm just building off of Peter's point. I think dialogue is going to be your best bet as you start your jobs. And so Waziri's, congratulations. I would really beg you to start having conversations with the different stakeholders, including the donors. So I see Homa Bay is already having a partners meeting next week before Christmas. So prioritization shows that you want to be introduced, have conversations, create room for dialogue. That's one. Two, you've all talked to some extent about fund flow. The one thing you've not shared with the Waziris is the issues around fund flow. So I would really like to ask the panelists to really be open and upfront, because where I sit as PEPFAR, for me as a donor, it's one of the biggest barriers to the success of counties, and you've just seen it from the presentation made by Danida. So I want to really ask you as panelists, what would you advise these folks in this room, especially those who are new, on how to tackle fund flow issues? And finally, you know, there was mention of, you know, if there's a strike, moved patients or services to the next county that has services ongoing. Before you do that, I want to remind you that COG has signed MOUs with faith-based consortium health communities, and there's a standing MOU that you as CECs have access to. In every county, you have a faith-based facility. In Kenya, there are 40%, over 40% of our facilities are actually faith community, faith-based facilities. So before you move your patients to other counties, explore those who are in your county. So I'm saying your conversations need to include all stakeholders, and remember those MOUs are sitting with COG, so please build off of those before you create or reinvent new avenues for maturing quality of services. Thank you.
Thank you very much. Do we have any question from here? Hakuna, please, this side. Begin here. Kajiado, my home. Nakuona.
Yes, mine is, I'm Daniel Yumbia, CC Health Machakos, formerly CEO KMBDC. And I'll refer my comments to Eugene. I will not ask you a question, but I'm going to build on what you've discussed about the sharing of specialists. I was the pioneer of that idea. We shared with the COG, we shared with the Senate and the National Assembly, and the only recommendation that we gave was that the counties divide themselves into blocks, like the Eastern Block, like the Lake region, and we said if you can get a cluster of 3 counties at least, then you get the data of who has what. Then you make arrangements. And the arrangements should be that, one, we must buy the so-called Prados, because these are senior officials, these are senior consultants, and we like to move them in comfort. If that could be done per cluster counties, and then you say, for example, the neurosurgeon covering the Lake region is based in Kisumu, and you liked the services of the neurosurgeon in Kakamega, there should be a vehicle set aside by the counties to move them from one station to another. There must be arrangements for accommodation, just like the way we saw with the Cuban doctors, where hotels were sourced, and these people would work from hotels for as long as 6 months. So we just need to say that these consultants can be moved from one county to another. They do the job there, and they move to the next station where they stay. So that is what we said. But then, I'll still talk about data. I've had a lot of talk about data here. And I'm a bit disturbed that nobody, and I repeat, nobody, has bothered to tell us the number of the nurses, the clinical officers, the medical specialists we are talking about per specialty. So which data do you have? Which information do we have to share? Because you can only share what you have. Therefore, it may be necessary for us as CCs for health to carry out evaluation on data for our counties, submit to the COG, so that COG also knows the number of health workers per cadre in every county. My friend on the other side talked about the specialists being more than the medical officers. Do we know the medical officers that we have recruited as counties? Do we know the nurses per specialty that we have in the counties? What resources are we sharing if we can only get that information from the medical council for doctors only, and we don't have data for nurses? I think this is something that we need to look at, and then we work on. Mine was a contribution because I didn't have a chance to be a panelist. I decided to be a panelist from my sitting point. So, I submit.
Kajiado, please. Kajiado.
Thank you. My name is Alex from Kajiado County. My questions go to THS. With the transformation THS has created, especially on the reproductive health, and now that the program is coming to an end, what next? Maybe you need to just tell us what next now for the program. Number 2 is Danida. For counties that have complied with the minimum conditions for the project, like transferring of money from county CRF account to special purpose account, the issue of counter funding, there is a delay in disbursement of money, and these are monies that really help us on the primary health care on level 1 and level 2. And thank you very much for introducing the concept, or rather for expanding on level 1, the community level, but also give us guidelines on how it will be used at the community level. But the major concern is the delay in disbursement of the second tranche. Thank you.
Asante sana. Kuna mwingine hapa? Okay. Oh, ngoja kidogo.
Thank you, Dr. Mbarak from Lamu. My query is to Madam Nosgard of Danida. Did I pronounce that right? Yeah. I'm very passionate about home-based care, and it turns out our governor has put it as a priority program in his agenda. Now, we had planned to, have something like a simple Excel data sheet whereby we'll capture the data of the patients who are, homebound, bedridden, extremely elderly, who cannot access health care, and so what they are suffering from, what their needs are, and such. So under the program that you plan to roll out, and I was very excited about it, and I'm hoping Lamu will be considered in the pilot for the level 1 support from Danida. Do you plan to have something like special software that will capture such a data from, the households? And is there a plan to train maybe the CHVs on something like that? The other one is just like a suggestion in terms of sharing of specialists. In the footballing world, they have something called loan, whereby if a player is too expensive in terms of their wages, what they do, they give the player to another county and then they share the expenses. So maybe the specialist may not be given, in totality to the other county, but the counties can share the burden of the salaries, so to speak. Thank you.
The last one, please.
Mine is not a question. It's I've been listening and following on what my brother Wesley was talking about. I think we need a uniform system, a system that is uniform. I've seen you talk about elephant and other systems that people have, procured across. But your boss spoke about a system that is being, that is at the level of the MOH. So if we have a uniform system across, it will help. Secondly, on Danida and THS, who have done very well. Odini, I'm happy to see you. I've seen you on a media platform, but I've not seen you physically. But one thing I wanted to say is sustainability is the key here. Because moving forward, these donor funds and the projects that are being run, they are getting out. We have constructed, we have done a lot of renovations, but at the county level, how sustainable are these at the county level? The facilities that have come up, how are we going to, what are the staffing level that we've put on at the county level? So basically, mine is a comment that we have done well, but from the MOH, if we can have a system that is across all counties that can be shared across, instead of having different counties getting different systems. Thank you.
Very good. Now, I'm sure my panelists are ready. Where should I begin? Nianzie wapi? Well, I'll start here. How many questions did you get? Briefly, please, or just move here. I think this one is working. And you're up.
Thank you very much, Waziris, for the questions and comments that you made. I think I'll start with a question from Kilifi County, Waziri from Kilifi, who asked that for the funds to level 1, will they be clearly earmarked? The answer is, I'd like to say yes, because we've been sharing the allocations. Maybe we'll be able to reshare that as we move forward. We've been sharing the allocations, clearly outlining how much is going to be from the Danida contribution, from the Danida side, how much is going to be the allocation for support to level 1, and how much is going to, of course, the county will be required to give as counterpart funding for each of the financial years over the period of implementation of the project. So that is clearly outlined. Through your coordinator, will be able to maybe reshare for your reference and information. Another thing is that whenever we disburse funds, we usually issue an official notification from COG that clearly outlines how much has been sent from the treasury and the period within which you are required to transfer the funds from CRF to SPA and subsequently to health facilities. So that will be coming once the funds are disbursed. One thing I need to mention, and Steen will emphasize on this, is that for the support to level 1, there is no requirement for the matching funds from the county. That only applies to the support to level 2 and 3 health facilities. So for the support to level 1, there's no requirement for the counterpart funding from the counties. I think Steen will also give more information on that. Then I think I was also asked about what next after the THS project. I think from our Waziri from should be Kajiado. We've been having elaborate programs and discussions with the county technical teams, the county focal persons, and the rest, just to ensure that we have elaborate closeout plans being put in place, and also with a focus on sustainability. If you look at what we've been sharing during the current ongoing performance review meetings, our focus is on sustainability after the project. What is the county having in place to ensure that adequate measures are put in place to have those activities, continuity in funding of those activities, and also to ensure that the gains we've made over the period of implementation are not reversed just because the THS project came to an end. So in my opinion, these sustainability measures are really county-specific, much as our colleague also suggested that we have something broad and standard from the national government. But a lot also has to come from the counties. I've seen a lot of counties talk around issues like passing of the FIF bills and the like that will also assist towards ensuring sustainability of these measures after the project comes to an end. I think on what next, the World Bank has indicated, though it's not confirmed, that another program may be coming after the THS project. Maybe 2 or 3 years after the THS comes to an end, we'll have the reports compiled, put together, lessons picked from the THS project. Because you remember, we had the previous KHSSP program from the World Bank, and a lot of the lessons learned from the KHSSP program were used in designing the THS project. So we'll have a lot of lessons picked, a lot of things to be learned from the THS project that will then inform that other project that is likely to come in the next 2 to 3 years after we close THS. Then the delay in disbursement, the last comment, the delay in disbursement of funds. You know, we have the county government's additional allocations bill, which of course has to be passed by the National Assembly and the Senate and enacted into law through, of course, the president signing. So if you look at the previous financial year, we had this bill being enacted on 13th of May. Like I mentioned, it was only 1 month to the end of the financial year, and therefore we were not able to disburse tranche 2 of that current financial year. What we did is that the county government's additional allocations bill for the current financial year 22-23, luckily enough, it was republished, and therefore we were then able to have those tranche 2 funds included in that bill. And we hope that now that I saw, or we heard that the president signed it into law early this week, we'll then be able to have these funds go out to the counties in the shortest time possible. Maybe Steen will also...
Okay, we have an interlude, but a very important one. You can sit, no problem. I have the honor to invite on this podium the permanent secretary. I'm told she's about to leave, so I'll be very happy to, and I hope you'll also be happy. Are you not happy? Makofi ko happy, jamani, ala? Yeah, she wants to say 1 or 2 things. Well,
is it afternoon or good morning? I've just been called back, so I decided just to wish you guys well. It has been insightful, as I said the first day. And I think you look like you guys, you're committed. Are we committed? Are you? Devolution has to work, eh? As I said, we have building blocks. We need only to put more. I have 2 key points to make. As you go in, remember, the right hand cannot work without the left hand. We need to have a relationship, and a strong one. And as I said the other day, seamless, both vertical and horizontal. However much you want to bring a lot of issues to be devolution, the national level is trying to resist, the county, I think there is nothing like that. I think you have seen the national government is giving you guys a lot of support. I was talking to somebody here to have a unified thing. Can the Council of Governors give all counties a standard template on planning? Ni kweli daktari? Dr. Osoro, is it good? So that when we come here, let's have a unified format. Whether we are applying for DANIDA, whether we have objective by JICA or CDC, let's have a standard template. Number 2, if the counties need directions on planning, do not hesitate to request from the national level. I know majority of us are new, but don't work on isolation. I said here the other day, and I think I'm not commanding, but we need to change our health system. We need to have a paradigm shift. Can we change from that style we are used to patient-centered approach? NHIF is just disbursing money. I happen to have cancer. You pay for me 3 million. Who follows to know the outcome of that patient? What is the value agenda of health today? SEC, what is your value agenda? We have disbursed about 20 million in your county. Who follows the outcome of those patients? Is our work just to give you revenue? We pay 2 million, the patient dies. Is that what you want? You are doing a lot of good work, generating a lot of data, and sitting on it. Kindly work with HIS. Let's document what we have. Let's even have bullets, maybe monthly, if not quarterly. Because these are the things which are going to guide us to make our policy implementation or policy framework. And I say, do not make policies which might turn against. We need to be guided by data analytes or data analytic. So that's my final word. But as we leave, let's look at the entity, not the functions. You talked about Port Health. You talked, can we get Saga? What have you done with that little resources you have? Let's not have much. We cannot be able to chew. Port Health, I told many people, and Professor Muga is there, he'll correct me. Port Health is an international health relation issue. Professor Muga, am I correct? Port Health is not a function of a county. It's a multi-sectoral. And that's why you find when you go and find a public health officer, there is a police. Kuna kwanga na askari? Do you have guys from immigration? So it is not a function that the health refused with it at the national level. It is multi-sectoral approach. So as we sit here and think of how do we widen our scope as a county and how do we improve our quality service, let's swallow what we chew. I always tell people, information is what? See, information is power. A lot of people say it about mess. Let me tell you, go back to 2013. Understand how mess came in. Let's not talk by hearsay. Let us be guided. You are all above 35. You cannot be swayed. You cannot be forced to sign a contract. Ni kweli. So I like talking the truth. And as you go to the new office, kindly set system and processes. Today is you. Tomorrow is somebody else. What will you be remembered on? Patient-centered, set processes, and system. That when you live there, I'm proud to stand here with Professor Muga because they said something. And that's why all of us admire them when they are seated there. What is our role and what is our take? It's just food for thought. But with me, I said my office is open. Any relationship we want to create, whether horizontal, vertical, I'm ready to give you all the support. But argue your case with facts and the truth. And you'll always be a free person in this world. Sawa sawa. I wish you well. May you become better than yesterday. May God widen all your horizon. And always think, what can I change from my point where I'm standing? Not us. If your county is better than mine, what do I borrow from the other county? Do I have to refer a patient from Nyamira to Kenyatta? If the services are being rendered in Kisumu, let's start talking to each other. Sawa sawa. Thank you so much, and may God bless you. Let's work together.
Asante, makofi. Na tafadhali usitoke. Just give us 1 minute. Just 1 minute. If you just hang on 1 minute, please. 1 minute, Prof.
Thank you so much. Moderator, I've been asked to come here and perform one function, and that is a function of giving a vote of thanks to Madam PS. And this is from my heart. The PS has done something that a lot of our government officials don't do. They come to open meetings and sometimes close and leave. They don't sit in to follow the discussions to understand the issues. This particular PS has chosen to act completely differently, and I'm very happy about that. I want to thank you for that. It is something I have complained about before, and Katra can tell you many times that I have had to sometimes mouth it openly, that we are discussing very, very fundamental issues, and these senior officers are the decision makers. And we discuss when they are not there to follow. We are happy that you sat in to follow. We know that very soon you will become very busy, but I will encourage that even when you become very busy, choose some specific meetings and ask your officers to plan for them very well when you can go and sit in and follow the discussions. You will make better decisions than when you just come in and go. I hope I'm speaking for all of us, but even as I thank the PS, you are also very senior officers. Pick that lesson from her. When you go back to your counties, there will be very many meetings in which your juniors are discussing important issues. Spare some time to sit in and hear them. You will make better decisions for your counties. So can we stand up and give very, very hearty claps to our PS for that very exemplary action she has done. So 1, 2, 3, funga, fungua. Thank you so much.
Thank you very much, Madam PS. Thank you very much. Safe journey. Now, we will be as brief as yesterday. So, okay, 1 or 2 minutes.
Thank you, Dr. PS. So I'll just go straight forward to the questions that were pushed my way. The first one was my colleague who asked why we could not implement the DHIS2. And I think all of us are quite familiar. Data is the new oil. So one of the few reasons as we move towards digitalization of health, the DHIS2 had very good programs, but we had issues, number 1, to do with privacy, number 2, security measures, because if there is any breach or a hack of that particular system, someone will have access to all the records of the 43 million Kenya. So we had to develop a system, number 1, that required a few fundamentals, and I think Dr. Stine should have shared with you. I've seen the slides. He did raise an issue about the unique identifier. So we needed, number 1, to develop a unique identifier system that will be able to work with those two systems. So the DHP, someone inquired about it. It's being piloted. We've already done the 64 module, ANC included, immunization, and all these other modules have been able to be done. There was a critical question about support of this system that we're developing. Number 1, the system is locally built by our own developers. That means they'll be available all through while we're working on it. We're also planning on having a responsive technical support at 2 levels. Each county will have their technical support so that in case there's any hiccup, I can't log in, I can't sign in, the support will be able to be provided. And we intend to have a 24-hour support system, especially when we deploy the system. My friend Idembo asked which investment in which ICT systems. I want to remind you that we've done a few standards. I think there's one called the Kenya Interoperability Framework. You can Google it. It's one that ensures even if you decide to do any system in Kenya, whether private or personal, there are a few standards that you must be able to adhere to so that they can be able to share systems. I would probably ask for those who have elephants, please ask the TA or the technical people in Elephant, are they adhering to the Kenya Interoperability Framework before you continue with that contract? 2, 3 things I've asked you. Ask them where the data is being kept. The Kenya Data Protection Acts demand data be kept in Kenya. If their servers are abroad, you're already breaking the rule. Have they registered with the data commissioner, either as data processors or data collectors? And number 3, are they adhering to the Kenya interoperability framework? There was another question that was asked about, Dr. Mbati talked about the uniform system. Now, the system we developed is based on microservice. That means within the hospital, for example, if in Nyamira, Wesley is uniquely identified. We'll have the system working within Nyamira, and once everything has been done, whatever has been done to the patient will go towards the shared health records. That means when you move from Nyamira to Kitui, whatever was done in Nyamira, through the shared health records with a unique identifier, I can be able to see what the patient received in Nyamira. I think those were the critical questions asked on my side. Thank you very much.
Thank you very much, Wesley, and do not go away. Stay.
Question regarding level 1. To CM Kajiado, there will be some guidelines, an advisory coming out from the COG on the implications. Vincent mentioned. There was previous communication advisory sent out earlier this year, but another important area. That's the level 2 and 3 health facilities. For motivating the CHV. So it depends also what's already funding for the 10 community units, which are already been selected, and we have the lists at COG. And now the bill, as soon as it will be approved, the county government additional allocation bill, the fund as soon as possible will be transferred to the SPA account and then to the health facility level 2 and 3. Thank you.
Makofi kwa Christine. Makofi tafadhali. Asante sana. Yes, Steve.
Yes, thank you very much. I will just address 3 issues very briefly. There was the issue of the L1 funding, and I just wanted to confirm what Vincent was saying, that the L1 funding does not require any counterpart funds from the individual counties, unlike the L2 and L3 funds, which do require counterpart funding. There was a question about when could the counties expect the transfer of the second tranche of the financial year 21-22 Danida primary health care funds. This is a question that we ourselves have been asking the National Treasury. National Treasury has been informed about the budget. They have received correspondence from the Ministry of Health regarding the itemized budget, and we are just waiting for a response from the National Treasury prior to dispersing these funds and then getting them out to the counties. So your question is very well taken, but unfortunately we have actually exactly the same question as you have, and we are waiting for information from National Treasury prior to be able to transfer the funds. I can just inform you that we have received an application from the National Treasury for the funds for tranche 1 of this current year. So even though we have received the request from National Treasury to transfer our funds to National Treasury for tranche 1 of this financial year, we have yet to receive their request to transfer the tranche 2 funds of the previous financial year. The gentleman from PEPFAR was asking about funds flow. The funds flow issue seen from our side is that we are very closely aligned, 100% aligned to the Kenyan budgetary and fund flow system. So, so whatever weaknesses and whatever strengths are in that system, those are the ones that also apply to Danida funds. Thank you.
Thank you, Steen Lassen. Makofi kwake. Please let us have some life in those makofis. Makofi kwake. Asante sana, Lawi. Eugene, it's your turn.
Thank you very much for the opportunity. I will try as much to summarize. I had about 7 or 8 questions, but one from Dr. Yumbia was a contribution and not really a question, and I thank you really for that. There was the first issue that was raised about the medical officers.
Can you hear him?
Are you able to hear me?
Maybe use this.
Thank you. I think the first issue that was raised was about employment of locals and disciplinary issues. My advice or my take on that will be that there is a law that actually governs the number of locals that you can actually employ. I think when you check the County Governments Act, it provides for the number of, I think it's 30% that you need to get from other counties other than locals. But this Waziris is a function for the CPSBs. Please respect them in their duties. You can have bilaterals, but also respect that there is that assignment of functions that this one is for the CPSBs. Disciplinary is also a function of the CPSBs, so please don't purport to discipline. Refer the issues to your CPSBs and always have cooperation and coordination. There was an issue about, I think in my presentation, I made comments about management and unionizing. Maybe just to appraise you, all these laws, the Labor Relations Act, the Employment Act, labor institutions, these acts were passed before the advent of the Constitution. They are all 207 legislations, some early 208. And as such, they do not provide for certain things. We have been clamoring for legislative review of this legislation so that they conform to the devolved structure. But nonetheless, I mentioned about a court case. So I think the question was, do we have our medical superintendents being in unions? Do they sign something upon employment? Well, it's not really necessary for them to sign, but the spirit and the tenure of that judgment was that if you are part of management, if you make decisions for management, the question was, are you unionizable? Will you want to speak for the management or for the union? So that is what balance you need to strike, because you can't purport to speak for both. Either you are in the union or you are in management, because when the union comes to speak to government, it's actually management that they speak to. There's really no one who's called government, but it's actually the management that they come to speak to. So colleagues, Waziris, please take note of that. Don't allow everyone to be in the union. Please, the people who manage health sector in your counties, please enable them not to be in the unions. There was an issue about training. I don't know what the issue was. Yeah, the issue was, will it be solved? I think the PS was here. She's opened her office for all of us. COG, we have been clamoring for this because it's really a need that is coming out from the counties. As the HR committee, we have had this issue outstanding, but now with the advent of the new management, let's try and keep pushing for it, because really, counties are really paying doctors who go to get trained, and they never, some of them never come back. That's the unfortunate bit. So it's something that we may also need to take to HR. But the training needs, you can manage the training needs. They are your employees. Ask them, what are your training needs? So that you manage it within some sort of rota. The issue of UHC staff, the question was, do we let them go? What happens after the lapse of their contracts? The question is really, do you have the budgets? You know, if counties do not budget, can they recruit? You understand? So, okay, no. Okay, there is an interlude. I think we may need to take a photo, and I'll hand it back to the moderator.
Yeah, just a minute, because one of us is leaving for the airport, and the tradition is that we take this photo. So who can help us with this table, please? Could someone help us with this table, please? So please come and stand here. Yeah. Kuna vijana hapa. Yeah, very quickly so that one of us can rush to the airport. And then you can finish quickly because we have another session. Utaweza? Ama niwasaidie? Okay. Kuja hapa. Photographer.
So as they continue setting up, I think I can just finalize my comments because there are, I think, 3 or 4 questions that were raised. The issue of UHC, I just concluded by saying we need a budget, and if not, we are going to clamor for a conditional grant to come to the county so that you can recruit, because counties cannot recruit without an attendant budget. The issue of strike engagements, yes, dialogue needs to be embraced. But as I mentioned, these issues are county-specific issues. The issue of promotions, the issues of PPEs, and so on and so forth. These are issues that we need to indulge our doctors. And dialogue really is the best way. COG, we took that position because we don't want a national strike. Yeah, if there is to be a strike, let it not be a national strike. And the more we talk to our doctors, medical practitioners, the more we resolve the issues. So in case there's a problem, you can always call on us. We are able to spearhead or advise in the dialogues. I think there was an issue of movement of patients from faith-based and all that. I think the spirit was really that we try as much not to have a nationwide strike, so that in case Kiambu is on strike, then people can opt to go to Nairobi and so on and so forth. And I can tell you it has worked, because I'm sure you've not had any strike for the past 3 or 4 years. It has really worked. I think the other one was a comment from Dr. Yumbia, and yeah, I think I've exhausted all. In case I may have left any, you are free to call on me even during tea time or lunchtime. I'll be able to converse. Thank you very much.
Mpema Kofi, Eugene Lawi, very good. You know, lawyers talk and talk and talk, so you have to be very careful with them. Thank you very much, gentlemen. Now the lady has gone. Thank you for a job well performed. Makofi. Now you'll give me just 1 second, but while I'm looking for that 1 second, Esther Somoine, please come on the stage so that we can proceed. Karibu, 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 karibu. Now, okay, now I have the pleasure. Ladies and gentlemen, may I draw your attention, please? I have a pleasure to introduce to you the representative from KEMSA, and this is Esther Somoine, former CCM Kajiado Health. So you can see we are smiling at each other. Don't ask us why we smile. We have been in the trenches together. So please go ahead and make your presentation for 15 minutes. Then we shall ask you questions. And after that, we want to go straight into the plenary, but I will have a discussion after your presentation.
Oh. Thank you, Prof. My name is Esther Somoire. I work with KEMSA. I support counties from KEMSA, and as Prof has said, I was CC Kajiado, second generation for 5 years. Before that, I was vice chair of the County Public Service Board, and out of that, I chaired the HRH committee in the caucus. I was also the treasurer of the caucus, doing supporting welfare for CECs. And I'm privileged to have had this opportunity again to serve Kenya in a different space, or to serve counties and our country in this space. And I must thank the COG team, because as you come in, I know we have a number of us who are county officers, who are public servants, and now you are state officers. And when I was moving to, I didn't know I'm a state officer and that the terms are different until July, when I was moving from Kajiado County to KEMSA. But I must thank COG, because they actually, PS ameongea mambo ya seamless. They supported my transition and they helped me settle in KEMSA. Dr. Nganda ananiangalia because, I'm scaring Dr. Nganda because, unajua amekuwa daktari, sasa yeye ni state officer. And the advisory we got from COG. So after these 5 years, there is a lot that you may need to learn about the next life. Sawa sawa daktari, utaniona kando. So I stand here on behalf of Terry Ramadan. Terry is our CEO. She was not able to come. She has a board meeting, and she asked me to represent her. Uko KEMSA huwa wananiita counties. Sometimes I actually forget that I'm now KEMSA, and I speak for counties all the time. And we are quite a number of us. We have some in Afya House. And when we go for meetings, wanasemanga counties. Mulikuwa mnasema aje, last time mkiwa the other side mnasema hivi, and now. So, but thank you so much. So I'll go straight to the role of KEMSA. The role of KEMSA at the county level is to procure, warehouse, and distribute essential medicines and medical supplies. We have 8 depots, only 2 are operational. No, we have 8, 2 Nairobi, 1 at Commercial Street, and a new one at our Embakasi office. We have 6 others in Nakuru, Nyeri, Meru, Kisumu, and Kakamega. The second function of KEMSA at county level is to establish a network of storage, packaging, and distribution to county facilities. And this, we do the last mile, except for Mandera and Turkana because of the security challenges. We also support county government to establish and maintain appropriate supply chain systems for essential medicines and supplies. This is done by our technical or our sales officers who are at regional level. Some are supporting counties at county level. We have 22 so far, but we have a new structure, and we hope to deploy more staff to offer technical support to county governments. And then, of course, collect information and provide regular reports to national and county governments on medical commodities supply. This we do through the Ministry of Health. We do monthly report to the ministry and, of course, to development partners who are supporting programs. The key metrics, we have the promotion of primary care facilities with required essential medicines and consumable commodities. I mentioned earlier that we do last mile. But we have had challenges, especially with the rural facilities, because they don't have the technical know-how, and we rely on historical data. They are not able to provide real-time consumption data to help with quantification. I mentioned earlier that Mandera and Turkana, we are not able to do last mile because of security challenges. Our turnaround time, that is from order delivery to returns. I can tell you, Saizi, we are a CC of health, whether you are a technical officer or not, you are expected to perform magic sometimes. And a lot of times even the governor will tell you, it takes about a month actually for the county pharmacist to consolidate data from all the facilities. And then of course scale down to the budget. It takes about a month, but when you send it to KEMSA, you expect KEMSA to process and do everything within a day, sindio? And even the governor will tell you, and the finance team will tell you, but we paid KEMSA yesterday, dawa iko wapi? So I know one of the things you'll be required to do ni kukua magicians. Ikilipwa leo, I was having a conversation with my brother Yumbia yesterday, because he called me out pale akaniambia nimelipa leo, wapi dawa? You know, I paid 48 million and I have an order, kesho nataka hiyo dawa. Kama hakuna dawa, hakuna Christmas. So, and it has taken them 1 month to actually consolidate the data and to place the order. But we've worked on our turnaround time from actually 48 days. Now we are doing 13 days. I know Tarakanidi, we did a record 3 days. Unajua, he was blackmailing me, ananiambia huwezi aibisha chairman ya COG Health Committee. You have to deliver this one within 3 days. But anyway, we are doing our best to improve on our turnaround times. And the other challenge we've had is expired products at facilities. Of course, this is beyond the mandate of KEMSA. And the best we can do is to make sure that we have drugs that have long shelf life. But I don't know whether we still have partners here, but it's one area that I would want to have a conversation with partners, especially with the supporting county with disposal of expired products. Because sometimes, because we operate in very political environments, and sometimes, you know, these challenges are actually within. You can actually have a staff, hata expired items umeweka kando. But even a sweeper anaenda saa ingine anapiga picha, ama you've not experienced that. And then your governor sends you, or something, you see it on social media, that there is a photo going around an expired item, imepatikana in one of your facilities. But when you follow up with your staff, unapata that is actually, yes, an expired item, imefichwa mahali, but that person akitaka kuwa malisha zanafanya nini? So we should be able to dispose these expired items in good time. So we are having a conversation with partners to see how we can support counties on that. And then, of course, frequency of stockouts of HPT, tracer items. I know I have that in a different slide on issues of order fill rate. And forecasting accuracy, we were at 20% the other day, but now we are at 50%. The challenge still, it goes back to the use of historical data to make decisions, because we are not able to get quantification data from our facilities. I don't seem to be... I need help, eh? Okay. On the support, the key matrix, okay. The functionality of the health products and technology units, you'll forgive me because we had to punguza this report to 15 minutes because initially I had 30 minutes. So the functionality, we have several structures at the county level that we expect you to support to be able to manage the HPT function better. We have the county health products and technology units. I am sure you're already briefed by the county pharmacist. We have county stores. In the first slide, KEMSA is actually supposed to help counties warehouse, but because KEMSA has not been able to do that, at Kajiado we actually built a drugstore at the county level. Because as much as KEMSA does the last mile, we still need to have buffer stocks at the county level and at the sub-county level. So the functionality of these stores will depend on, of course, resource allocation at the county level and inventory, of course, management. This KEMSA will support with the technical support. We also need to invest in ICT infrastructure to be able to make all these structures functional. We also need to have functional, relevant procurement committees. Having served in the county level and interacted with my colleagues for the last 5 years, I know devolution, Professor, devolution happened, and then sometimes devolution imehang mahali. And I've had this conversation even with my sister Ruth in Nandi, because some counties were able to devolve further to the department level. I know Makueni, I think, has been doing that. So we have the county procurement department, finance, and they perform the procurement function. Some counties have been able to devolve further to the department level, and health does their own procurement, of course up to a certain level, maybe up to 4 million or 5 million. Others, and of course those with FIF that have passed and are implementing their FIF laws, they are able to actually make the hospitals procurement entities. And when you look at counties that have been able to operationalize their FIF bills, they are able to actually procure directly from KEMSA. And when you have challenges with KEMSA, with the main county account, most of them wanapita kando, wanachukua na hospitali, sindio? When you have a functional FIF. So if we can support these structures, then I think we'll be able to actually work better, have commodities in good time, and able even to manage those accounts with KEMSA and other suppliers. And then a commodity procurement and supply plan. What happens? Sometimes unaambiwa, we have 2.6, and Professor Mtaha, you know we have very big budgets for health. When you look at the county budgets, utasikia health has the highest budget, but how much of that budget are we able to access? How much of that budget? The HPT budgets, when you look at the HPT budgets, unapata umeambiwa 200 million, but the much you are able to access and pay KEMSA and other suppliers is probably 100 million. The other 100 million, financially ikiisha, imeenda hivyo, sini recurrent. So how can we ring-fence? You know, through FIF, they say we are able to ring-fence the health funds, but that is only revenue. What happens to the money that comes through there? How possible is it, Professor? Can we have that as a conditional grant to the health department? I think that is a conversation we need to have with the health committee. We shared that with several governors 2 weeks ago when we met them in Diani, and we are hoping that this caucus would actually be able to have that conversation. And of course with Professor Muga as a consultant, sioni tukishindwa sana, sindio? Thank you, Dr. Then now I want to go to process, the selection and quantification. I think I've already talked about forecasting and supply issues. We've been using historical data. It is not always accurate, but what we have done, initially, of course, you know, selection, quantification is usually a function of sales, the commercial department, and then procurement does their thing. But what we are doing now at KEMSA, and I know that is what happens at the county level, we give our request to finance or to procurement, but our technical officers, how are they involved in the process of procurement? And you know, I am speaking as an insider, and I know what happens in counties. And now, we need to actually be more involved in the process, even where procurement has not devolved further to the department. Because the technical officers, most of them actually who are wanaletewa kusign evaluation reports. Ni ukweli? Who is doing a second term? Ruth. See, that is what happens. Eh? How do you ensure quality? So what we are doing at KEMSA now, we are doing joint market research. It's an interdepartmental affair. It's no longer just a procurement affair, so that even the officers that are working with counties directly are involved in the process of procurement, of market research. So we are making it more inclusive, so that we can all own the outcomes. My colleague mwenye sasa ko health Kajiado, Kilowa, Waziri, he used to be in roads. And one time, and nisamehe tu I'll share, one time we had a project that was, you know, engineers wakaenda wakasema it's complete and it's paid. Si ni vitu tunafanyika kwetu, si ndio? And then I went there, we went to hand over the building, na ijapakwa rangi, ijafanywa nini. Then I asked Waziri what happened, and even me, I don't know what happened. Yes, and of course, see, we are family. So we need to promote and push for inclusion. Sindio? These functions, you can only be held accountable kama uko involved. Lakini huwezi kwenda kudefend kwa county assembly a process yenye haujakuwa involved. And of course, that way you're able to get the best price, the best quality, the best everything. Sindio? Because it actually happens in almost all institutions. But what we are doing now at KEMSA is we are making sure that everyone is involved in all, in the entire process. Again, on selection and quantification, our processes are guided by, of course, the Kenya Essential Medicine List. This is currently being reviewed, and I know COG is involved. I know Dr. Nyinge has been part of this process. I think the rest I had already talked about. On procurement, I think we have now a supplier performance score. I know there's a time we had a challenge with pricing. That was around June. And I think the commodity yenye ilisumbua sana was gloves. At one time, I think we are giving almost 2 or 3 times the market rate. But I think there was a global challenge, and this has been addressed. But now we've also introduced supplier performance to make sure that we get the best prices. We vet suppliers. And of course, when you look at the Kenya Kwanza manifesto, we recently had a review of our strategic plan, of course, to align with the Kenya Kwanza manifesto. And one of the things that we saw is that, of course, they want to leverage on economies of scale. So we will be doing bulk. So of course, that we make sure that we get the best prices for counties. The updated procurement plan, one of the things that I saw or I learned, you know, for the 10 years that I worked in county, sometimes we do these documents. How many of us are involved in the development of our procurement plan? sometimes we do them to tick boxes. And I have been, nimekuwa hapo. So because we are supposed to upload, to do a procurement plan, but I want to ask you to just, make sure that you familiarize with these documents, even as we forward, even as we beat the deadlines, so that you can guide your team well. Of course, we have technical officers, even for counties that have not been able to devolve to departments. We have seconded officers from finance. Please sit with those officers and always make sure that you know what is in the procurement plan, what is in the supply plan. That is what we are doing now. We will be sharing this. I am hoping we'll have a forum. Katra, tutapanga forum ya CEO na CEC, sindio? Sometime. So I've already dealt with the pricing issue, the order and delivery, supplier performance, and now on quality assurance for HPTs, we have a very well-equipped laboratory that is ISO certified with additional quality control systems. The HPTs that you get from KEMSA, before we even make the actual procurement, the supplier lazima alete sample, it is taken to the lab, it goes through the entire process, quality assurance, and so you can be assured. And this is, yesterday somebody talked about the act that was done sometime 2 or 3 years ago, compelling counties to only buy from KEMSA. It was actually more of a quality control measure. I know it was not well delivered, but, and that has been lifted. But this is a sector that has to be regulated, not just because I work with KEMSA, but this is a sector that has to be regulated. You know how porous our markets can be, and we cannot afford to have our citizens exposed, sindio? So if we are doing that kwa mambo ya mimea na human life, so we need to always make sure that we have the best quality. So for KEMSA, you are assured of quality. We have most of the suppliers, or all suppliers, must always, they hold the dealer license. We always make sure that they have the manufacturer license, and all the licenses that are required by, there are no shortcuts. On warehousing and distribution, we have good warehouse practices. Sasa nitakimbiza tu, we have a new warehouse in Embakasi. It's well automated. It makes it easier to load, and this will also help in reducing our turnaround time. We used to outsource vaccine storage. But now with the new warehouse, we do our own storage. It has good capacity, and it makes it easier to handle HPTs. And the policies that inform our processes, the only items that we actually, most of the quality assurance processes are done in our lab. For program items, there's a specific test that is done at the National Quality Control Lab that is not available in KEMSA, and that is only for program items, and that was a demand by the donors. But we are working, of course, to also have capacity to do this in our KEMSA lab. On management support, county health, the functionality of the structures that I talked about before, the county HPT units, a dependable and information system to ensure visibility of data. We are working to review our LMIS and our EMR system to allow for end-to-end visibility. I had something on the issues that have been raised before, but maybe that we can deal with the question and answer. So thank you very much. If there is anything I have left out, please, I had to punguza these slides. So if there's anything that I haven't covered, I think we can do it during the question and answer session. Thank you very much.
Makofi kwa Esther kaa tu hapo. Usitoke hapo. You know, I found it difficult to throw you away, but now you have done very well. Now, we need to agree. I want to ask for a few questions to Esther so that some of the issues that you may have missed, if I can get one question, I'll be very happy. So, any burning question? Oh, okay. Mpe mic tafadhali. Only one. It's because of the time. We will give this material, and I want to see Khatra in the future, a whole session for KEMSA. Maybe one day or a half day.
Yeah, thank you, Chair. My question is, you did mention that KEMSA, you don't have the data for consumption data. But personally, I'm aware that the ministry, under the systems that have been presented under the Kenya Health Information System, they are collecting consumption data since March 2021. So that means we have 20 months data, consumption data, across all our health facilities. Is there maybe a problem in terms of using that data to model so that you are able to improve in terms of your fill rate? Because imagine you are at 50%, and that is essential medicine that we are talking about, not the other medicines that we require for highly specialized cases that we have. So is there any challenge? Is it finance or what? Because it's not the data, because we have the data now in KHIS.
Thank you. I didn't get your name. But yes, the consumption data that I am talking about at the facility level, we actually, as KEMSA, we do not have the consumption data. And I think that is something we need to take up with the ministry, because that is one of our greatest challenges. Of course, with the fill rate, it has, chairman actually spoke about it yesterday. Right now, counties owe KEMSA actually about 4 billion, because the county accounts alone is 3.5 as at yesterday, and for GOK facilities is over 500 million. So for us to be able to pay our suppliers and improve on our fill rate, we need counties, who are our main customers, to pay their debts on time. Of course, we are working on we want to do a bit of diplomacy now, because when we talked about ring-fencing money for health, of course, by extension, we also hope to be able to ring-fence money for the HPT budgets. Sometimes we've even been asked to review our business model. Meds, I think right now, you pay upfront. Cindy? So we don't want to do that with KEMSA, because KEMSA is not only doing business with counties, KEMSA is a service delivery institution. Of course, it's not for profit, but we need to actually, support KEMSA to be able to improve on the current fill rate. We were at 30% 6 months ago. Now, last month we were 60. Now we are down again to 50. But we are hoping by January. We know counties right now financially, you are like 3 months behind with the exchequer releases. And that is why we are not, we are opening accounts as soon as you pay something kidogo, we are able to supply. But Daktari, we will work with the ministry to see what they have at the moment. But for KEMSA, we've not been able to access any data to inform our procurement process. Thank you.
Esther, I want to apologize because you know because we have to collapse the next session so that we can have elections before. Yes, please.
There's one last slide that I hadn't shared on no. There's one last slide. Am I? Imebadilishwa. It was on the documents that you may need to familiarize yourself with. You will share the presentation. Yes, the key documents that will help us as we begin e-Safari. Finally, I want to thank you all for your time. I wanted to share my number. I know I may need to meet each one of you individually. Just drop a text with your name and county so that I'm able to save. And finally, I want to say we've talked a lot about 48 governments, 47 county governments, but there's only one health system. Ama kuna ingine? And for those of us who have served in the first term, we talk about functions when we are comfortable, kama saa hizi. But when there is a crisis, everybody, like for COVID, everybody was doing everything. Yumbia is not here. But a referral system, hakuna private, hakuna public. When there is no ICU bed, you will call Nairobi Hospital to ask for an ICU bed. So we only have one health system. We need to deal with cross-border issues. I was having a conversation with my sister from Busia on border counties and what we can do and the issues that we need to pick with partners on border counties and the burdens we have to carry because of the commitments that our national government is making at the regional level. And of course, the other cross-border issues with counties. We have a duty to support each other because when one collapses, you remember for the central team, when Kirinyaga was having problems, the influx yenye ilikuwa Embu and the surrounding counties. When Nairobi was having a crisis, Machakos, Kajiado, and Kiambu are having, you know. So we have a duty to support each other. Even with the economic blocks, I know the social sectors were left out. Si kwa economic blocks, health hawakuagi. Ama mnakuanga? Usually, the social sectors are left out in that conversation. That is what is happening with the EAC. So we have a duty to support each other. And as KEMSA, we will be there to support you. And as Esther, even in my personal capacity, I am always available to support our counties, not just on HPTs, on every other area that I believe, on partnerships, Prof. Thanks. So my number is 0726 904 808. 0726 904 808. Esther Somoire.
Makofi kwa Esther Somoire. Makofi. She had a very tough task to present a very huge document in a very short time. Now, may I draw your attention to the program? Please look at the program because I want to negotiate now. It's time for negotiation. From what I see, it is 20 minutes to 1. And the thinking here is that by 3, we should be through with everything so that those who are getting flights earlier travel safely in time, and those who are staying can also do other related activities. And therefore, 11:45 to 12:15, we were supposed to have 2 papers, 2 presentations. That's on page 5 of your program. Look at page 5. The first paper, this particular presentation is supposed to be County Health Service Delivery, and it had two presenters, that is Dr. Khatra Ali and Mr. George Capillo. The idea of this presentation was to create an environment for the session on page 6. If you look at page 6, you will see that from 12:15 to 1:15, which is 1 hour, there is a panel of discussion chaired by Dr. Emmanuel Wamalwa. Now, the proposal I put to you is as follows. If you all agree that we must be out of here by 3, then the presentation by Dr. Khatra Ali and Mr. George Capillo is collapsed into 5 minutes. If we do that, and banking on the fact or understanding that the panelists are very well informed individuals, and they are very familiar with service delivery, they should be able to answer key questions. We already have the questions ready, and we want to put the questions to them, just similar to the panel which was here yesterday, attended by the justice from the judiciary. You saw the format of questions, so that now they will be engaged at that level by Dr. Wamalwa, and they'll be able to answer questions and also take questions from the floor. If we do that, then we can go for lunch and come back for the elections. So then, do I have support to collapse these two into 5 minutes? Wangapi wanaunga mkono? Hapa kuna crisis. Asanteni sana kwa popular support. George, 5 minutes, please. 5 minutes, and then we go into the plenary.
Yes. You can talk from here.
Thank you. I have a quick announcement regarding the elections that you are supposed to have. The procedure that we will follow, I know many of you either are very anxious or are desirous of certain positions. So I will make the following announcement. The positions that are available are chair, vice chair, we have the secretary, and the treasurer for your own welfare or for other purposes. And what we'll do first is declaration of interests. I know you have been talking in your groups, in your own caucuses. So we will invite that the members who are desirous of contesting for the positions, they can just declare their interests through our colleague, Kerubo. Kerubo, you are there? Yeah, Kerubo is there. Lynette, you can be able, I don't know whether everyone has seen Kerubo or they know Kerubo. So you can get the declaration of interest to her. You can just give in your name plus the position that you intend to contest or vie for. And then, well, previously at the council, at the governor level, we have been having these elections annually. And it was consensus. It has always been consensus since the inception of the council. They go down, they meet, they talk. Of course, the people budge out of positions. Negotiations, I'm sure you are aware of how negotiations are carried on, and I know you've been lobbying in your various groups. So at the governor's level, we've been always having consensus since the inception of devolution. Mebo, my colleague, can correct me if I'm wrong. It has always been consensus. We always have ballot boxes, but we've never gotten to that point. So, Waziris, if you're here and you are contesting, I'm sure you've been talking in your groups. Please allow room for discussions. Maybe you may budge out from the position that you are not supposed to, but it has always been consensus. Now, failure to agree, then we go into the balloting. But I think consensus usually is good because it comes from the parties, and it means that you are willing to work together other than a contested balloting process. So that is the announcement that I want to make. We have two options: consensus or now the election. But that is for you. You are the caucus of CCM Health, so you are the ones who will be able to decide. For us as the council, we are impartial, we are not biased, we will be able to work with any leadership. It is going to come from yourselves. So thank you very much. I want to hand over back to the moderator.
Thank you very much. As the presentation is going to proceed, may I ask the panelists, Dr. Amalo, please come forward, and want the following to also come forward so that we have a seamless handling of this exercise. Dr. Bashir Isaac, Minister of Health. Bashir, njoo hapa tafadhali. Meshak Ndolo. Meshak Ndolo is here. Okay, then Robert Thuo. Meshak Ndolo and Robert. Who is representing Meshak Ndolo? Doctor? Dr. Samora, where are you? Meshak or Samora? Asante sana. Samora Machelo Otieno. Si ndio hivyo? Eda, you have no choice. I just made sure that you come from a different constituency, so you must be there. And you tell us the story of those guys, how you deliver service to your enemies. Robert Thuo. Ameka, oh yes, sikuona. Sawa, I'm done. Omaro, do you have chairs? Enough? 5 minutes. Bila kuja, sita kuja hapa. 5 minutes, tafadhali.
Good afternoon, everyone. Good afternoon, everyone. Mine is just a precursor to the discussion that is coming up next. And it's about how we conceive service delivery in our counties. So I'm just going to give a brief precursor of what service delivery in our counties looks like or ought to look like, so that it gives the team that is coming after me in the form of a panel discussion more in terms of how then do we as incoming CEC conceive what ought to be a perfect service delivery in counties. So because our mine has been collapsed to 5 minutes, I'll just do a quick overview and stress the fact that in as much as we are new teams that are coming into the counties, building new teams to help in the service delivery in our counties, we need not to lose focus on the building blocks of health service delivery. And again, when you look at those building blocks, there are key aspects of them that are very key and very important, and they are looked into as one. And what we need to do as new CECs that are coming on board, and those that have been in place, is to make sure that the key building blocks, the block of health service delivery, health workforce, information, medical products, vaccines and technologies, and financing, and more importantly, that leadership is looked into aggressively. What we are talking about here is that we also need not to lose our mind or our focus on the principles, key principles of health service delivery, the issues to do with coverage, the issues to do with equity, the issues to do with patient safety, the issues to do with geographical coverage of where our facilities are, and more importantly, the issues to do with the aspect of quality of care. So even as we are overseeing county health management teams, as the drivers of health agenda in our counties, we really need to focus so much more on the principles of health service delivery. I believe few of them will come out of the panel discussion that is following up, and we need not to lose sight on that, so that even when we are building county health management teams that we oversee, that will help us oversee health service delivery in the country, we make sure that they work within those key 8 principles of service delivery, taking cognizance of the fact that the building blocks of service delivery must be viewed as one and handled as such. So I would just want to conclude by stressing and more importantly, urging our incoming CCs, and of course the ones that have been on the trade for long, that service delivery, health service delivery in our county is something that we really need to look holistically, and making sure that when we are looking at it holistically, we take cognizance of the fact that the teams that we are building up, or the teams that are helping us to deliver this particular agenda in our counties, are aware of that fact. Lastly, in conclusion, just to give way for the panel, there's a consistent question that has been coming up all along, that do the services that we offer in our counties good enough for us to utilize as CCs or as county health management teams? Funnily enough, and my colleague Robert would bear the witness to this, when we work and engage our counties, one question we always ask is like, okay, for the last 3 months, how many of you have benefited from county health facility services? And funnily enough, a few of our CC are here that we've engaged. The question that we get in those sessions is that the only time I've visited a public facilities in my county is when I've gone to check on a sick relative, or when I've gone to take a sick relative to an hospital, but not me as a person utilizing those services. So in discussing health service delivery, we start from the point that we need to make sure that we have services that we as leadership of these particular counties are confident enough to utilize. If we do that, then we will be on the same path. With those many remarks, let me give way for the panel so that the panel discussion starts. Thank you so much.
Makofi kwake, amefanya kazi nzuri sana. Now I give you the power to lead.
Thank you very much, Professor, for giving me the power to lead. So we are getting into a very interesting discussion, ladies and gentlemen. We have taken the past several days to talk about different elements that build a good service, healthcare service. I have very eminent persons here with a lot of experience. You are looking at over 100 years of experience right here. So you need to wake up and let's discuss about health service delivery. And how we'll organize this is very simple, is that I will first introduce my panel, and then I'll pose questions to them and they respond. And after that, I'll welcome about 2 or 3 questions from the floor, and then they'll respond to that. So pretty straightforward method. I'll start from here, the right, and we have the honor and pleasure of hosting today, this afternoon, Dr. Bashir Isaac, who's the head of family health at the Ministry of Health, over 23 years of experience in the field. And really, he has experience way beyond working with the ministry. He has headed programs outside within the UN family, and one that struck my attention is the DIFPAC project, which really targeted 24 counties with support from DFID. So kindly help me welcome Daktari through applauding him. Next, we have Mr. Robert Thuo, the CC Health Nyeri County, but also I think it's acting here, and he's really full CSC in the finance sector. So we'll be really hearing some insights from the finance side in terms of how do we bring in this, but also have some questions from him when we talk about health proper. So kindly let's applaud him. Dr. Samora, quite experienced in the health sector. The immediate, I think most of you might know him from FCDO, a development partner, but quite a lot of experience in the development world, over 15 years of experience in that, supporting different programs, different activities on the development partner stage, but he's here from IQVIA, which really is a firm that helps governments and other agencies manage their health better. So, Daktari, karibu sana. Let's give him a round of applause. And lastly, our very own Dr. Eda, one of the survivors, as he referred to himself, serving under multiple governors as CEC Health, and that shows you that there's really something deep in there that leads into that. So he has chaired the caucus of CECs, and I will be asking him to share some of the insights that he's gotten from that, in addition to his own experience. So as you can see, quite an eminent panel of persons here. And before I start, I would like to just request you to stand up. Just let's stand up in recognition of the fact that you've been seated for quite some time, and just stretch yourself up so that just swing a little bit. Yeah, you can do what Prof is doing. Yeah, then let's sit down. I'll also request to be assisted by removing this stage here so that my panelists can be visible. So I'll start with Dr. Bashir. And Dr. You've been in this sector for a while. You've been within the ministry after devolution. And one of the roles of the Ministry of Health has been around guiding policy, developing policy, and helping provide direction for the country when it comes to policy decisions. How exactly does the ministry do this, and how can counties be involved? How do you ensure that the policies you develop are done in an inclusive way and that they are good for the Kenyan citizen? But while at that, Dr. you can also talk about something that I know is dear to your heart, the issue of adolescent pregnancies, which is running away so fast in this country. How do we deal with that? Thank you.
Thank you, Dr. Emmanuel. Good afternoon, honorables. First of all, I want to thank the COG for organizing this induction. I think it's very crucial for us to communicate and know what our roles are from the onset so that we can have a smooth service delivery for our population. Coming to the question on issue of policy formulation, we know the division of segregation of duties in the national government and county. We are not oblivious to the fact that health is a devolved function, and we are happy with that as ministry, because the closer we take service to the people, the better. Our policies are usually or should be aligned with our guiding documents. We start with the SDGs. Some are global commitments and some are national commitments. The SDGs, the Constitution 2010, the Kenya Health Policy Framework, and the Kenya Health Strategic Plan. These are all documents that help us formulate our policies. Policies are formulated for our own population, and there are two different levels of government, and the deliverer of the service must be involved in terms of the policy formulation, because we use the data from the ground, we use the experiences and expertise from the ground to ensure that we are making policies that respond to the needs of our population. Much as we get guidelines and directions from WHO and global literature, we take that literature, customize it with the expertise that we get from the ground, and therefore policy formulation, much as it is a national government duty, but should be co-created, because we are not working in vacuum. We are all working together for the same nation. Our vision is the same. the existence of the Council of Governors has made it very, very possible in the ease of delivering on this agenda. And therefore, COG being the conduit for coordination of this is a very important and positive agenda that we need to applaud as a ministry. I was part of the 2013 team in the ministry before I stepped out for a short stint. The environment was very toxic at that time. But I think 8-9 years down the line, things have really improved. And we are now, everybody's finding his footing. And we know we are Siamese twins that cannot be separated. You separate